Well, good morning, everyone, and welcome to the WPS-GHA presentation on Pulmonary Rehabilitation Services. My name is Ellen Barra, and I'm going to be your speaker for today. Also on the call with us today is Leanne Foster, my friend and colleague, who will be watching the chat and will be reading off the questions to us. The first slide that we have up here for you is our disclaimer slide. And we do include this on all of our presentations. The information that we're going to present to you today is as accurate as we can make it as of today. However, if you've been with Medicare for any length of time, you know that Medicare rules do change often. And we're in a period of time in the year where CMS published the proposed rule. They're looking at all of the comments. There will be the final rule that will be published at the end of November. And so some of this information could change. All of the relevant laws, regulations on the CMS website are the final determinant of coverage along with your documentation. We will provide responses to your questions based on the question that you have asked. However, again, Medicare rules will determine that final coverage. And then the last bullet point, CMS does prohibit recording of this presentation for profit-making purposes. We would request that you do not record and you do not do screenshots as we're going through the presentation. We are recording this and we will have this available as an encore presentation, and you'll be able to access that through our website in the training section, and then there's a whole header that says encores, or you can go straight to our YouTube channel and go into the playlist for encores, and this will be here. CMS, as you're aware, is kind of an alphabet soup. So what we have done on this particular slide is provided you with the acronyms that we're going to be using during the presentation today. We wanted to provide this to you as a reference, so if you get to a particular slide that you're looking at and we've got an acronym there, you're not sure what it means, you can go back to this one to figure out what we're talking about. If you've not already downloaded a copy of our presentation, you can go into our website, which is the WPS-GHA. Well, now I just forgot our website address, WPSGHA.com. You can go into topic centers and then training and then live events. And there will be a link there for this presentation where you can download the material itself. So what is our objective for today? Well, we want you to understand the rules and regulations for Medicare payment of pulmonary rehabilitation services. This particular topic was a suggested topic for education through the use of our survey. At the end of our presentation, we will have some survey links, a QR code where you can take the survey. And part of the information, or one of the questions on that survey, is what additional education would you like to see? This is one of the topics that had been suggested multiple times, and therefore we pay attention to those surveys, and that's why we're doing this presentation today. So what we're going to talk about is the patient eligibility, the provider eligibility, who can actually perform the service, the coverage guidelines, and then we're going to talk about the most common denials. This slide that we have up here for you now is really a slide based on the CMS emphasis, I guess you could say, on health equity. So what you can see here is that for beneficiaries that had a pulmonary rehab service between January 20 of 23 and June 20 of 23, the drastic difference between non-dual eligible beneficiaries and dual eligible beneficiaries. Now, what we mean by that is non-dual eligible beneficiaries are those beneficiaries that have Medicare only. Now, they may have a supplement or a Medigap insurance, but their primary payer and uh, the entity that pays the bulk of their services is Medicare. Our dual eligible beneficiaries are those patients that have both Medicare and Medicaid. And as you can see on this slide, there's a pretty drastic difference between the amount of services being provided to the dual eligible patients and those provided to the non-dual eligible patients. So really, we're just providing this particular information to you um, in order to make you aware of this particular disparity. And as you're providing these services and looking at those patients that would be eligible for pulmonary rehabilitation, to really kind of keep this in mind. This particular service is a great service for patients who have breathing difficulties, who are having pulmonary problems. And this service can really affect the patient's health and their quality of life. In addition to that, receiving this service for those patients who are eligible can really prevent them, in a lot of cases, from having to have additional services, having to go to the emergency room, for an example, or something else. So the next slide that we have here is a definition of pulmonary rehabilitation. And you can see here it's a multidisciplinary program of care, patients with chronic respiratory impairment that is individually tailored and designed to optimize physical and social performance and autonomy, and an evidence-based, multidisciplinary, and comprehensive intervention for patients with chronic respiratory diseases who are symptomatic and often have decreased daily life activities. So that's what the pulmonary rehabilitation services are all about. You can see in here it's individually tailored. We'll talk about that in just a minute. It's multidisciplinary, so there are a lot of things that are included in with this. And the goal really is to increase that patient's ability to take care of themselves, their ability to have a good quality of life through the use of the pulmonary rehabilitation services. So what we have next here is we have definitions for two of the providers that would be part of this program. Now, your medical director is the person who oversees the PR program at a particular site. So XYZ Clinic has Dr. Smith, who is the medical director. That means that he or she is going to be overseeing that program, making sure that the requirements by Medicare are taken care of, making sure that the program itself is working for those patients. And you can see there that they're involved in directing the progress of the patient itself. Now, the supervising physician is the one who is responsible for today's service. These could be the same person, it could be a different person. It's kind of just how it works in your office. Now, you can see here under supervising physician, it says immediately available and accessible for medical consultations and emergencies. Immediately available means right now. We've received some questions about, well, can the supervising physician be in the ER taking care of patients? Can they be up on another floor, etc.? That's really not immediately available. That supervising physician needs to be located within the same office, not necessarily in the same room with the patient, but they need to be where they can immediately go and assist with any problems that the patient may have. So if you have a situation where you have a doctor who's in the ER, for an example, okay, let's kind of talk about that one. Is that the same location what you could consider to be the same office suite in essence for that ER physician to be able to take care of that patient. And if that ER physician is seeing patients within the ER, can they immediately leave the patient that they're seeing over here and come and take care of your PR patient? If that definition immediately is not there, then that could not be the supervising physician. The 2024 CMS proposed rule is proposing to add physician assistants, nurse practitioners, and clinical nurse specialists to those that are or that can be a supervising physician. Now, whether they will continue that through the final rule, obviously we don't know that information yet, but you do want to watch for the final rule and the information coming out from CMS to determine whether or not these three additional specialties can function as that supervising physician. In addition to that, that supervising physician can also be available through telehealth, through audio video communications. And it does have to be video communications where they can actually see that patient. So let's look at some of the requirements. Well, they have to have expertise, obviously, in dealing with patients who have respiratory difficulties. They have to have CPR training or advanced cardiac life support. And then, of course, they have to be licensed. So what does this mean for you then? Well, what this means is that if Medicare should request it, you need to be able to show the expertise. You need to be able to show the CPR training. This could be certificates, it could be identification of additional classes and instruction that the medical director or the supervising physician may have taken. So let's talk now about eligible patient conditions. You can see the first one here, moderate to very severe COPD, defined as the GOLD classification 2, 3, and 4. So what is the GOLD classification? Well, that's an acronym that's back in your list, but it is the Global Initiative for Chronic Obstructive Lung Disease. And there are four different classifications. Classification 1 is very mild, 2 is moderate, 3 is severe, and 4 is very severe. So in order for a patient to qualify, you have to have moderate, severe, or very severe. The next part of that is when referred by the physician treating that chronic respiratory disease. So that means that your ordering physician for this pulmonary rehab has to be the one who is actually treating the patient's breathing problems, the respiratory disease itself. So what we mean by that is that, let's say you have a primary care practitioner, they're not treating the lung disease, but they really believe that the patient could benefit from this. They can't be the ordering physician. It does have to be the person who's treating that disease itself. And then the second classification is with confirmed or suspected COVID-19, and they're experiencing persistent symptoms that have lasted at least 4 weeks. This could be some of your patients, I think they're called long haulers, where the effects of the COVID-19 disease itself and infection itself really is lasting a lot longer than for some other people. You want to identify that treating physician within your documentation, and you need to work with them to get the information you need in order to support the service. What is their classification? How long has their respiratory dysfunction lasted? Pulmonary rehabilitation services are once per lifetime for that patient. So regardless of what other changes to the patient's condition may occur in the future. The pulmonary rehab really is once per lifetime. So what are some of the components then of the service? Well, physician prescribed exercise has to be part of that. That's going to increase their lung function, kind of help their endurance. You also need to provide education or training. Now, education or training is going to be how are they going to adjust to the instructions that you're giving them? What are things that they need to be doing at home in order to support their lung function? Obviously, if the patient is a smoker, education is going to include the fact that they need to quit smoking and then support for that. Psychosocial assessment is also part of this service, and we'll talk in more detail about that in just a second. Excuse me. You have an outcomes assessment, which really identifies how this program is working for that patient. And then you need to have an individualized treatment plan for the patient. So let's talk about these in more depth. Well, the physician prescribed exercise is going to include what's listed there on your slide: aerobic exercise, other exercise activities, conditioning, breathing retraining, step therapy, strengthening for the patient. And it has to be individualized for that patient. Now, in a lot of situations, there are protocols, kind of starting points for uh, pulmonary rehabilitation, but it does have to be individualized for your patient itself. For an example, if you have a patient who has had a double amputation, as an example, you're not going to prescribe for them the fact that they need to do so many steps on a stair step machine or something along those lines. So it will be individualized for the patient. What the physician determines is going to be best for that patient, the different types of exercise and things that they need to do, and specific to the goals that that physician has for that patient. Let's talk about education then. It needs to clearly be related to the individual's care and treatment. And so your documentation will support that. If you have a particular exercise that is prescribed for that patient, that may not necessarily be part of the standard protocols for pulmonary rehabilitation. You want your documentation to show why this particular exercise or activity for that patient is going to take that patient further down the road to meeting your goals. Again, tailored toward the individual's needs. And you want to look at the goals that you have for the patient: more independence in the activities of daily living. You want to help that patient understand what their limitations are going to be with this pulmonary disease that they have, and help them to adapt to that. Um, if you have a patient who has COPD, maybe you have a conversation with them about, running or attempting to run a marathon again is really not going to work for them. And how can you help them adjust to that? How can you help them with the limitations that they're going to have? Instructions about, okay, maybe you can't bring in, 4 bags of groceries all at the same time because you're going to lose your breath, but you can make more trips coming in from the car with your groceries and carrying smaller bags at the same time. That's instructions to them on how to adapt what they're doing in order to address the limitations they may have from the from their pulmonary disease itself. And then, of course, that next bullet there: improved quality of life. Again, this is a great service. It's educating the patient, it's providing exercise, It's giving instructions on what the patient can do at home, and that really can make a big difference in whether or not they actually can carry any groceries in. I know my mom had COPD before she passed away, and there were things that we did for her, um, or things that she decided to do that would help her still maintain her independence. For her groceries, as an example, rather than carrying them up the stairs going into her house, she was able to place her grocery bags on the landing, and then she'd only have to go up the stairs once and then would be able to carry the groceries into her house. That's an adaptation, but it also improved her quality of life. She was able to maintain then her independence. And of course, it's going to be related, any of the education you're doing is going to be related to that respiratory problem management. The next thing that we have then is the psychosocial assessment. So you're going to be talking to your patient about their emotional well-being, their mental health in dealing with the respiratory problem that they have, in dealing with the changes that they will need to make um, in their limitations, in the activities and things that they can do. It's also looking at, based on the patient's emotional functioning and mental functioning at this point, how do we kind of move past that in order to get them to do the exercises, to get them to understand the training and to adapt to the training that we're providing. Obviously, it's going to be related to the individual's rehab or respiratory condition. You also want to look at an assessment of the individual's family and home situation. So, are there animals at home, and is that making their breathing more difficult? Is there air conditioning in their home? Is there adequate heating in their home? Is there someone who smokes in their home? Um, what does the patient and the family kind of are they on board, let's put it that way, with the treatment plan and the treatment goals and things that you have set for that patient? Are they trying to push the patient too hard? Are they trying to discourage the patient from an active involvement in the pulmonary rehab that you're proposing for this patient? And then you want to look at the individual's response to and their rate of progress under the plan. Are they really on board with that? Do you need to be a cheerleader for them and really encourage them and provide that very upbeat, rah, rah, rah type of atmosphere for them in order to encourage them to comply with the program? Or for this patient, do you really need to practice tough love with them? You're going to adjust that to the patient and to their response, and then their attitudes and their willingness in order to comply with the program itself. And then you need to do an outcomes assessment. And this is really an evaluation of the progress of that patient. You're going to measure the patient's functions, and this will be their breathing functions, their exercise limitations. Kind of, you're getting a picture of where they are at the beginning of this program. And then you will do the same thing at the end of the program that will be able to support how this program has been beneficial to them. You're going to have objective measures of their exercise performance. So this will be the patient can walk for 30 minutes on a treadmill, or they can walk for 15 minutes going at 2 miles an hour, and you want them to be at 4 miles an hour. So these are going to be the things that you're really assessing for that patient. You can also see program staff measurements. It must be evaluated by the physician developing or reviewing the plan. So your clinical staff are the ones who are more than likely going to be doing these outcomes assessments, but it's not just information that goes in the chart. That physician who is developing the plan and then reviewing the plan on a periodic basis has to be using that information in order to do so. And then the last one is the patient's self-reported information. If you're asking them to do 15 minutes on a treadmill, for an example, at 4 miles an hour, do they feel like that's too much? Do they feel like they're losing, their breath when they're trying to go 4 miles an hour? And so therefore, do you need to back that off a little bit? And then their behavior. Are they really kind of exerting themselves to a certain extent in order to comply with the program and really in order to help themselves, make excuse me, make changes and then really improve their activities of daily living, improve the functions and improve their breath control, etc. We've kind of talked about the individualized treatment plan a little bit already, but these are some of the things that you need to include. Obviously, it has to be specific to the patient. You want to identify specific goals. Is part of the goal to raise the patient's oxygen level? Identify where they are and where they where you want them to be. Is it functionality? Again, identify where they are and where you want them to be, what you believe the PR service will actually provide for them. The plan must be established, reviewed, and signed by the physician every 30 days. This is part of the pulmonary rehab. It's not a separately billable evaluation and management service. Has to be done within every 30 days. So you really want to watch your times and make sure that your physicians are getting those evaluated, reviewed, and signed at least every 30 days. And this would be by your physician, your supervising physician, or your medical director of that program. So where can these services then be provided? Well, they can be done in the office. They can be done in an off-campus provider-based hospital outpatient, 19, or an on-campus hospital outpatient place of service, 22. Services can also be provided through telehealth using audio-video communications. Currently, this will last at least through 12/31 of 24. Um, in the proposed rule, the information is listed in Table 9 that these services will not continue after 12/31 of 24. It is the proposed rule, so I don't know obviously what CMS is going to do with that in the final rule, but you do want to watch for that. So currently, if you are providing this service through telehealth, then you would have the place of service where you would normally have provided it. In this case, on this slide, we've got 11, 19, or 22, and then you would use the modifier 95. If this service does continue as telehealth, then after that, you would use the place of service code 02, identifying telehealth, or 10, identifying telehealth in the home without that modifier 95. You can also provide these services in an institutional claim, and you can see there the 13X for outpatient hospital, 85X for critical access hospital. Now, one of the things that you want to kind of look at, especially if you're providing these services in place of service location 19 or 22, is who's going to bill for the actual pulmonary rehabilitation service. Is it going to be the facility? in which case you'd bill it on the UB04 form using the 13X or the 85X, or is the physician going to bill for that using the CMS 1500 or the 837P electronic format, and then use those place of service codes? So both entities can't bill for the same service. So you just want to make sure that there's communication there to verify who's actually going to submit the charges for the pulmonary rehabilitation itself. So now let's talk about units of service. The procedure codes themselves do not have time attached to those or in the description of the procedure code, but Medicare does have time attached. You can see here that you can have a maximum of 2 1-hour sessions per day with a minimum for 1 unit of service at 31 minutes. Now, if you do additional services, um, you are doing the 2 1-hour sessions per day, then you would need to have at least 91 minutes. The 60 minutes would go toward the first service, and then at least 31 minutes more in order to bill a second service on that day. Medicare can allow up to 36 sessions. If you do have sessions over 36 and your documentation supports the continued medical necessity of the service, the continued progress of the patient, then you can bill those sessions over 36 using that KX modifier. By using that KX modifier, you are attesting to the fact that you have documentation to support the continued medical necessity of that service. And then after 72, Medicare would not make any further payment. When you're looking at the time factor, this is the time when the patient is actively engaged in the pulmonary rehab service. So they're doing exercises. You're instructing them on exercises that you want them to do. You're providing them with education. It's an active involvement. If the patient says, hey, wait a minute, I need a break, and so they go in and they sit in a chair for 15 minutes, that 15 minutes does not count as the time of the service. So you'll need to have a way to be able to watch that so that you're not including that time. The patient decides to take a bathroom break or take a phone call or whatever. That time does not count toward the minutes of service that go along with this. They have to be actively engaged. So here are the two procedure codes, the 94625 and 94626. And you can see the difference within these services is without continuous oximetry monitoring or with continuous oximetry monitoring. That's the only difference between the codes. Now, again, in Table 9, in the proposed rule, the 94625 is not proposed as a permanent addition to telehealth services after the waiver ends. The proposed rule does not address the 94626. So I don't know whether that one will continue or not. So you want to watch the final rule for that. You want to watch the list of telehealth services. So let's talk about a situation where your patient has been receiving the pulmonary rehab services. They're making great progress. You provided them with 36 sessions. Through your evaluation of the patient, you determined that they would benefit from an additional 36 sessions. So they've had those. Medicare's paid for those. But now those 72 sessions are done. However, you believe that It is still a benefit to the patient to continue receiving these services, and the patient wants to continue receiving these services under your physician supervision and your clinical staff supervision. So what do you do at that point? Well, at that point, you can provide the patient with an advance beneficiary notice of non-coverage, or an ABN. What this does for you is it allows the patient to have the information on why Medicare will no longer pay any additional services. And it also then gives the patient the choice as to whether or not they want to continue, and whether or not they want you to submit the claim to Medicare. Now, the ABN is not automatic, in fact, should never be automatic. Um, but if you believe that Medicare is going to deny the services, and it's generally a medical necessity issue or it's a frequency issue, and this would be a frequency issue more than likely, then you alert the patient to that by using that ABN. And then when you submit the claim to Medicare, you append that GA modifier on your procedure code. Now, the GZ modifier we've listed for you here identifies that you believe you should have given the patient an ABN, but did not, and Medicare will automatically deny that. It doesn't go through any type of review or anything else. We have information available in our YouTube channel um, concerning the appropriate use of the ABN modifiers. So you can check that out if you want to. The next thing that we have then is denials. And what I find interesting is the fact that of the top 3 denials, only one of them really pertains to the service itself. The first denial that you'll see there is that the patient has Medicare Advantage, which means that the claim should not have come to us. It should have gone to the Medicare Advantage plan itself. This is really something that you can take care of with your frontline staff. You've determined that the patient is going to be receiving pulmonary rehab. As part of the questions and kind of getting your ducks in a row for billing and setting up appointments, you need to be asking the patient if they have Medicare Advantage. In addition to that, you can use our transactional portal that will tell you whether or not the patient has Medicare Advantage. Once they tell you that, then you know who you can bill for. By submitting to us rather than the Medicare Advantage plan, it really just delays your payments. And this is also true for situations where Medicare may be the secondary payer. Um, Again, you can find that information within the transactional portal. You can also, and you also need to be asking your patient questions on this. The next one that is listed there are duplicate denials. We've provided a YouTube on duplicate situations and ways that you can prevent these. And really a duplicate denial is just causing you more work. It's causing us more work too, but it's also causing you more work. When Medicare denies a service as a duplicate, we are saying we've already paid for this, and so we're not going to pay for it twice. So I know through hearing from some provider organizations that some billing services, some provider software has kind of an automatic rebill built into their software, and you really don't want to do that. And especially you don't want to do that for Medicare. If you have submitted a claim to Medicare and you have not received payment, your first step is to investigate what happened with that original claim. Did Medicare deny it? Maybe you didn't append the KX modifier. Maybe there was something technically wrong with the claim, and so we rejected it or as unprocessable, or we did a return to provider. whatever the situation might be. But your first action is to determine what happened with that original claim. Now, again, if you receive a duplicate denial, we're saying we've already paid it. So either it was a previous claim that completed as approved, maybe it went to the patient's deductible. It could be a claim that's currently in process. Maybe we're having to develop for some additional information. There could be multiple reasons, but prior to resubmitting that claim, investigate and determine what happened to it. This really will just save you time in the long run. If you investigate to begin with, then you're not wasting your time submitting a second claim. You're not having to wait for us to submit the remittance notice to you. And then you're especially not having to wait to go through the appeal process. 95% of the time, we're going to come back and say it's already been paid somewhere else. And so that just takes a lot of time for you. It takes a lot of time for us. So use the portal and the claim status section of that portal to determine what happened with that original claim. And then services exceeded. That's where you've gone over the 36 and your next service, you did not include that KX modifier, or you have gone over the 72 units of service that Medicare can make payment for. Currently, our transactional portal does not show the number of services paid for pulmonary rehab. There's a couple of things that you can look at. Number one, talk to your patient. Have they been receiving this service from someone else? And how many services did they receive from someone else? You also want to count up the number of services that you're providing to make sure that you know the number of services and where that patient is as far as your services are concerned. So as I said, this information is not in the portal at this time. However, we have surveys on the portal where you can indicate that you would like to see this added to the portal so that you can go and use that information to show Medicare has paid 10 services already or 12 services or whatever. And then when you submit that in those surveys on the portal, then that will be added to the priority list for future updates to the portal itself. So the next thing that we have for you are resources. We have a Code of Federal Regulations listed there that talks about pulmonary rehab. We have a Modifier KX fact sheet, and we also completed a Modifier Monday just recently on Modifier KX. You can find that also on our YouTube channel. There are a couple of places where the CMS Internet Only Manual talks about pulmonary rehab, and those are listed for you. And then the last one is the list of telehealth services, where you can go and see what you can provide through telehealth and what you cannot. So we're going to stop there for just a second. So Leanne will ask again if we have any questions.
We do not.
Okay. Then on behalf of Leanne and myself, we want to thank you very much for your attendance today and listening to the information we had on pulmonary rehab. You can now disconnect. Have a great day.